Welcome back, friends. I am Leema Rosemary, Assistant Professor, PG and Research Department of Biochemistry, St. Joseph College of Arts and Science, Cuddalore. Now I am going to talk about liver function test. What are the functions of liver? Liver performs several important functions. First one, metabolic functions. Liver is the central organ. It is actively participate in all the metabolism such as carbohydrate, lipid, protein, etc. Then second important function is excretory function. That is bile pigments, bile salt and cholesterol are excreted in the bile into intestine. Then protective function and detoxification. Kupffer cells of liver perform phagocytosis to eliminate foreign compounds. Then ammonia is the best example. It detoxifies to urea. So liver is responsible for the metabolism of xenobiotics. The next function, hematological functions. Liver participate in the formation of blood, synthesis of plasma proteins and destruction of erythrocytes. And finally, storage function. Liver stored glycogen, vitamin A, D and B12 and trace element. What is liver function test? The liver function tests are the biochemical investigations to assess the capacity of liver to carry out any of the functions it performs. Liver function test will help to detect the abnormalities and the extent of liver damage. Then classification of liver function test. Test based on abnormalities of bile pigment metabolism. Then second one, test based on excretory function. Then test based on changes in plasma protein. Then formation of prothrombin by liver. Then test based on liver spots in carbohydrate metabolism. Then test based on detoxicating functions of liver. First one, test based on abnormalities of bile pigment. The bilirubin is estimated by Vandenberg reactions where diazotized sulfonuric acid, that is sulfonuric acid in HCl and sodium nitrate. It reacts with bilirubin to form a purple color complex isobilirubin. Normal serum gives a positive Vandenberg reactions. When the bilirubin is conjugated, the purple color is produced immediately on mixing with the reagent. The response is said to be Vandenberg directive positive. When the bilirubin is unconjugated, the color is obtained only when alcohol is added, and this response is known as indirect positive. Suppose both conjugated and unconjugated bilirubin are present in increased amount, a purple color is produced immediately and the color is intensified and adding alcohol. Then the reaction is called biphasic. Interpretation of Vandenberg reactions. In hemolytic jaundice, unconjugated bilirubin is increased, hence Vandenberg test is indirect positive. In obstructive jaundice, conjugated bilirubin is elevated and Vandenberg test is direct positive. And in hepatocellular jaundice, a biphasic reaction is observed because both conjugated and unconjugated bilirubins are increased. Bile pigment in urine. In all cases of jaundice, urine should be examined for the presence of bile pigments, bile salt and urobilinogen. Only conjugated bilirubin is soluble in water and is excreted in urine. Hence in pre-hepatic jaundice, when unconjugated bilirubin is increased in blood, it does not appear in urine, hence called achloric jaundice. But in obstructive jaundice, conjugation of bilirubin is taking place, which cannot be excreted through the normal passage, and so it is regurgitated back into bloodstream. This is then excreted through urine. So in obstructive jaundice, urine contains bilirubin, hence in old literature it is called chloric jaundice. Urobilinogen in urine. In case of obstruction, bile is not reaching the intestine, and so urobilinogen may be decreased or absent in urine. In hepatocellular jaundice, urobilinogen is initially elevated, then decreases or disappears. Urobilinogen is absent in urine when there is obstruction to bile flow. The first indication of recovery is the reappearance of urobilinogen in urine. In hemolytic anemia, urobilinogen is increased, bilirubin is detected by Faucher's test, and urobilinogen is detected by Ehrlich's test. Bile salt in urine. Normally, bile salt such as sodium salts of tyrolic acid and glycolic acids are present in the bile but are not seen in urine. Bile salt in urine are detected by Hase test. Positive Hase test indicates the obstruction in the biliary passages, causing regurgitation of bile salt into the systemic circulation, leading to its excretion in urine. Next test based on excretory function, that is Bromosulphthalein test or BSP dye test. The ability of the liver to excrete certain dyes, example BSP, is utilized in this test. In normal healthy individual, a constant proportion is removed per minute, that is 10 to 15% of the dye. In hepatic damage and insufficiency, BSP removal is impaired by cellular failure, as damaged liver cells fail to conjugate the dye or due to decreased blood flow. Removal of BSP by the liver involves conjugation of the dye as a mercaptide with the cysteine component of glutathione. The reaction of conjugation of BSP with glutathione is rate limiting, and thus it exerts a controlling influence on the rate of removal of the dye. Procedure for the BSP dye test. With the patient fasting, inject intravenous slowly an amount of 5% BSP dye solution, which contains 5 mg of BSP per kg body weight. Withdraw 5 to 10 ml of blood 25 minutes and 45 minutes after the injection and allow these specimens to clot. Then separate the sera and estimate the amount of dye in each sample. Interpretation. In normal healthy individual, not more than 5% of the dye should remain in the blood at the end of the 45 minutes. The bulk of the dye is removed in 25 minutes and less than 15% is left at the end of 20 minutes. In parenchymatous liver diseases, removal proceeds more slowly. In advanced cirrhosis, removal is very slow and 40 to 50% of the dye is retained in 45 minutes. Test based on synthetic functions. Liver synthesized plasma protein, albumin, globulin, etc. The determination of total plasma protein and AG ratio yield most useful information in chronic liver diseases. Liver is the site of albumin synthesis and also possibly of some of alpha and beta globulins. Interpretation. In infectious hepatitis, quantitative estimation of albumin and globulin may give normal result in the early stages. Qualitative changes may be present. In early stage, rise in beta globulin, and in later stage, gamma globulin is rise. In obstructive jaundice, normal values are the rule as long as the obstructive jaundice is not associated with accompanying liver cell damage. In advanced parenchymal liver diseases and in cirrhosis of liver, the albumin is grossly decreased and the globulins are often increased, so that the AG ratio is reversed. Such a pattern is characteristically seen in cirrhosis of the liver. Then formation of prothrombin by liver. The liver synthesizes all the factors concerned with blood clotting. A decrease in the concentration of clotting factor is found in the impairment of liver function. This can be assessed in the laboratory by measuring prothrombin time, which is prolonged in patients with liver damage compared to normal. This test is useful to assess acute as well as chronic liver damages. Besides its help in the prognosis. Vitamin K is required for the synthesis of blood clotting factors. Therefore, vitamin K deficiency can also cause prolonged prothrombin time, which must be ruled out before drawing conclusion on the liver functions. This is done by measuring prothrombin time before and after administration of vitamin K. Prothrombin is synthesized by the interpretation. Normal levels of prothrombin in control give prothrombin time of approximate 14 seconds. Results are always expressed as patient's prothrombin time in seconds to normal control value. In parenchymatous liver disease, depending on the degree of liver cells damage, plasma prothrombin time may be increased from 20 to as much as 150 seconds. In obstructive jaundice, due to absence of bile salt, there may be defective absorption of vitamin K, hence PT is increased as prothrombin formation suffers. Prothrombin index. Prothrombin activity is also sometimes expressed as prothrombin index in percentage, which is the ratio of prothrombin time of the normal control to the patient's prothrombin time multiplied by 100. Thus, normally index is 70 to 100%. The critical level below which bleeding may occur is not fixed one, but there is always possibility of this occurring if prothrombin index is below 60. Then test based on detoxicating function of liver. The Hippuric acid synthesis test is the best known test for the detoxicating function of liver. Liver removes benzoic acid administered as sodium benzoate either orally or IV, and it combines with amino acid glycine to form hippuric acid. The amount of hippuric acid excreted in urine in a fixed time is determined. Procedure for hippuric acid test. 1.77 gram of sodium benzoate dissolved in 20 ml of distilled water as a sterile solution given intravenously. Shortly before the injection, the patient empties the bladder, which is discarded. The bladder is emptied after 1 hour and 2 hours after the injection. Interpretation. In normal healthy individual, hippuric acid equivalent to at least 0.85 gram of sodium benzoate or to 0.7 gram of benzoic acid should be excreted in the 1 hour or equivalent to 1.15 gram of benzoic acid in the first 2 hours. The excretion of small amounts more than above indicates the presence of. Then last one, test based on liver pot and carbohydrate metabolism. Galactose tolerant test. The normal liver is able to convert galactose into glucose, but this function is impaired in intrahepatic diseases, and the amount of blood galactose and galactose in urine is excessive. Advantages of this test: it is used primarily to detect liver cell damage, and also it can be performed in the presence of jaundice, as it measures an intrinsic hepatic functions. It may be used to distinguish obstructive and non-obstructive jaundice. Methods, and this can be of two types: oral galactotolerant test and IV galactotolerant test. Oral galactotolerant test. This test is performed in the after a night fast. A fasting blood sample is collected which serves as control. 40 gram of galactose dissolved in a cup full of water is given orally. Further blood samples are collected at half an hour intervals for 2 hours. It's similar to glucose tolerant test. Interpretation: normally or in obstructive jaundice, 3 grams or less of galactose are excreted in the urine within 3 to 5 hours, and the blood galactose returns to normal within 1 hour. In intrahepatic jaundice, the excretion amount to 4 to 5 gram or more during the first 5 hours. Thank you.